Okay? Central ray is still going to be directed at the base of the third metatarsal. All right. By the way,
The third metatarsal.
What's that?
It's not on the third metatarsal, the central ray over there, on the picture. On the other one,
here.
on the actual.
On the actual-
I mean,
on the girl laying
dorsal
down.
part.
On the actual patient,
Actual patient.
see where it's at, the central ray is on the current ankle.
It's like in the medial.
It looks like, yeah, it looks like it's going towards the ankle a little bit. Again, it's point of view. It's how we're looking at the image. So it may be, it's probably just the way we are looking at this particular image shows that it's probably not in the right spot. And that is okay. Okay, go by what it says here. So here's the by the way. When you're shielding your patient, what is the minimum requirement for gonadal shielding?
0.5 millimeters.
0.5
Millimeters of lead.
millimeters of lead or equivalent. Do you guys understand what equivalent means? What it means is that shielding, there are other materials that are used for shielding other than lead that are more lightweight. Okay, when we say equivalent, we can use material that has the same attenuating abilities as 0.5 millimeters of lead, which means I can use aluminum, I can use stainless steel, I can use cotton, I can use rubber, as long as it has the same attenuating properties as 0.5 millimeters of lead. Does that make sense?
Mm-hmm.
Okay. So gonadal shielding is 0.5 millimeters of lead or equivalent. The aprons that we use, the aprons that are hanging in our rooms, is that 0.5 millimeters of lead.
I think it's different.
It's only half the amount, 0.25. Yeah, it's only 0.25. Why? Because that shield is to protect us from scatter radiation, which has less intensity.
That's
than
for
that
us,
of
right?
primary
It's
beam.
not,
That's for us.
it's not for the direct beam.
Okay? So, this is one of the biggest mistakes that I see technologists do, is they use the lead apron to shield their patients. It's only 0.25. Okay? So when you're going to shield your patient, you make sure it's gonadal shielding. Not protective aprons or protective shielding that we use as technologists. It has to be gonadal shielding. Okay? It's probably happening to your kid, right?
I don't know.
How?
I just have a question.
Yeah.
For the shielding, after a long period of time,
Mhm.
does it become less effective? Does it break down?
It doesn't become less effective. What happens is that from poor handling, poor storage, okay, crumpling up, throwing it on the table when you're done, it'll bend,
Something we've all done.
it'll crack. So the material actually, it doesn't become less effective, it becomes less effective by the poor handling of technologists.
So structurally it becomes less.
Structurally,
As long as you
it
take
starts to
care
break
of
down.
It should just last. It'll always.
Right, if you take care of the lead, it should last. So going back to what you're saying, we do a quality assurance exam on all our aprons where we lay them under fluoroscopy and we do a visual check under x-rays to see if there's any pitting or cracking of the material. And if there is, then we get rid of it. Yeah.
Just patch it up.
Yeah.
Oh, duct tape.
Duct tape. Duct tape fixes everything.
As long as it's the equivalent, right?
Yeah. All right, true lateral, okay? So lateral of foot, we're going to have them frog leg their leg out, okay? They're going to be frog leg, and it's a medial lateral projection because you're entering the medial aspect or medial surface of the foot and exiting the lateral, okay? In doing so, you may have to put a support or bolster under your knee, because what we're trying to do is we're trying to get the foot in a true lateral projection, like this, true lateral position. If they put their leg all the way down, there might be a slight obliquity of the foot, so we're going to prop up their knee to get it in a true lateral. And what we're doing here to make sure it's a true lateral is we're looking at the plantar surface of the foot. Okay, we're looking at the plantar surface of the foot and making sure that it's perpendicular to the image receptor. Okay? So in a true lateral projection, the central ray is going to be directed at the base of the third metatarsal. Third metatarsal. But as I'm going to tell you guys, when you're practicing and role playing, what do I always say?
Put the part in the middle.
Get the part in the middle of your field. Just get the part in the middle of the field. Now, you want to include all the way from your heel to your toe, and you also want to include the distal third, this distal third of your tib fib. You know what I mean by tib fib, right? Okay. So the lower third of your tib fib.
So it looks like the IR is kind of angled, or is it?
Yeah, the angle that's so that it's matching the length of the foot. And you guys can do that too.
Okay.
Yeah, so you can angle the tube to match the length of the foot. Is there anything wrong with this image?
It's not collimated.
Is it, okay, it has to do with collimation.
The shadow of the toes are.
The shadow of the toe. Are we cutting something off?
Mhm.
We're going to cut something off. So they need to open it up a little bit more to include the toes. Or move the foot to include the toes. So I can move the foot back or open up the collimator just a little bit more to include the toe. Okay? But if you're moving the foot back, make sure you're not clipping off the heel. Okay, here's the alternate, which is the lateral, medial, lateral foot. Not common, but again, if the doctors request that, then that's what we're going to do. Why would we do something like this? Okay, remember, if there is an area of interest, we're trying to get that area of interest as close to the image receptor as possible. So this is for, if we're looking at the medial aspect of the foot, we're going to get closer to the image receptor for better detail. That's the only reason why you would do that, okay? But rarely is this done. Look how uncomfortable that it looks, okay? Open up the collimator to, again, include the distal part of the tib fib, a third of the tib fib, okay? So the entire foot should be visualized. The tibio-talar joint is demonstrated. The metatarsals are going to be superimposed with optimal exposure factors. All right, Katie. There it is. Okay? So this is one of the projections and views that would be used to evaluate the arches of the foot. So this is AP and lateral weight bearing. Here it shows abnormalities of the longitudinal arches and structural injuries to the ligaments like a Liz Frank injury. Liz Frank injury has to do with the separation of the, let me see if I can get you a foot. Okay, so Liz Frank's usually occurs somewhere here at the base of the metatarsals, and there is a separation. The separation of this area here, also causing injury to those ligaments. That's a Liz Frank's injury.
Is it always between the second and third metatarsal?
No, it can be any one of those, but it usually happens at the base of the metatarsals. Okay. So in this particular projection, the patient is going to be standing up. It is weight bearing. We do it bilaterally. So you want to include both feet, both foots, okay. Both feet on the image receptor, say collimate to include both. And we are going to direct our central ray approximately, again, 10 to 15 degrees towards the heel. But we're not physically directing our central ray on the foot. We're going to be between the foot at the level of the base of the metatarsals.